It's all survived week one. Somehow you got through it. Okay, well, that's good. On to week two. Freezing cold outside, right? Anybody else wake up and go, why the heck do we live here? Do they have that conversation that I've had every day? All right. Can't remember, did I have the front lights lowered? Those aren't the front lights, those are the back lights. All right, so we're gonna continue on with hematology today. Yes, here it is yesterday. Last week, we talked about pain. Okay, so what are some concepts or takeaways that you can remember that you've studied that you think of as we go through the pain, as we talked about the pain unit? What's some takeaways? What are some meds? What are some interventions? Let's start in the back row. Anybody in the back row? Something that we can, that you remember, or take away from pain. Right. So it might be different than your patient who comes in who is acutely ill, right? You may have to give them more and more food. You may not be looking at their respiration rate, right? So it's more of the comfort versus. Good. Anything else, Bethel? Yeah, right. So look at those different, a lot of different pain scales, especially in the pediatric book, right? Is it appropriate for the child? Is it appropriate for the adult? Right? Not every adult is cognitively aware and could use the 0 to 10 scale, right? They might have to use a FACES scale. They might have to use a Black scale, okay? Shayla won't pick on you since you're the only one in that room. Let's help me too.
Chronic and acute.
Okay, chronic versus acute pain, okay? What about it?
That acute is something that's going to happen immediately.
Okay.
Chronic is something that, is it 3 months?
Usually 3 months or longer. Can acute pain turn into chronic pain? Okay. Is the way we treat acute pain and chronic pain differently?
Yes.
Yeah, okay, so tell me about that, anybody? What would be different on the way we treat acute pain versus chronic pain?
Chronic pain, you're going to like avoid opioids because there's long-term side effects, whereas with acute pain, you can do more intense drugs to help with pain relief.
Good, okay, so what were some of those long-term effects that we talked about, or side effects for opioids?
GI
Okay,
upset.
GI upset, nausea, vomiting, respiratory depression, addiction, dependence, sedation, right, all of that, okay, good. And then what did you say about acute? Did you say acute?
Yes, it's like opioids can be used more frequently
Yeah.
just because they're not going to be used long term.
Right, yeah, and what were some of those opioids that we talked about?
Like more
Morphine.
hydrocodone,
Hydrocodone,
fentanyl.
fentanyl, yeah, okay, good. All right, so what about other medications we could use for chronic pain?
NSAIDs,
NSAIDs,
Tylenol.
Tylenol, acetaminophen. What else? What were some of those other maybe co-analgesics that might be used? Gabapentin,
Ketorolac.
Torlac, yeah, those would be an NSAID, yep, good. Anything else?
Weren't there some like antidepressants and antidepressants
Anticonvulsants,
that could be used too?
yeah, what were those called that we talked about? They're often used for neuropathy. Did we already say that? Maybe we already said it. Gabapentin, did we already say that?
Yeah.
Okay, gabapentin, tricyclic antidepressants, amitriptyline, okay. How about lidocaine? Could lidocaine be used?
Yes.
Okay, good. All right, how about this row? Just the two of you. Anything else we can add to what we talked about with pain?
Like the 4,000 milligrams for
Okay, good. 4,000 milligrams for acetaminophen, because if we give an overdose, what does that affect?
Liver.
Our liver. Okay. If we already have some underlying liver disease,
That's lower.
that have to be lower. Yeah, good. Okay, how about this row?
Be assessing pain, like all the things that come with that. like,
Like what? Remember? Talked about the pain scale.
Location,
Yeah.
like things you ask.
Yeah, intensity.
Makes it better or worse.
Anything that makes it better or worse. Location, the scale,
Past interventions.
yes, interventions you've used. Yeah, good. Should you be asking those questions every time you're assessing pain?
Yes.
Yeah.
Good pain assessment. All right, how about front row? Anybody else, anything else to add?
PCA pumps.
Okay, PCA pumps, what about them?
For those who can actually function.
Yep. Okay, can children use them?
Yes.
You still the age.
They do.
So are they cognitively able to understand and push the button, right? Okay, good. Well, and we'll talk a little bit more about PCAs today, kind of about the really different types of PCAs there might be. One might be basal, continuous, right? And then you also may include a demand dose, right? Where they push it and you get the medication. Good, good review. Pretty much the main point. Good. Good paying attention. So. You were quiet, right? You were retaining, so that's good. All right, here we go. Hematology. So this will be the second unit that we'll cover. So remember our tests on Monday will cover pain and hematology. Okay. All right, so we're gonna lecture a little bit. We've got our case study to go over that you guys worked on today. And I have some other activities for us to work on to hopefully make this information a little bit easier for you. So hematology, so some things. All right, so hematological changes. So there are some changes that occur as we age, unfortunately, as we get older. Okay, we may have a decrease in blood volume as the patient gets older. Our bone marrow is going to produce fewer blood cells. Okay, what does our bone marrow produce? When we talk about fewer blood cells, what are we talking about? Red blood cells, white blood cells, platelets, right? Okay, so our white blood cell counts can get lower as patients age. Lymphocytes are less reactive. Okay, so we might not have that aggressive immune reaction when an older adult maybe comes into contact with a new antigen, new virus. Okay, WBC's counts don't increase as high with infection as it does with younger adults. Okay, any of you guys work long-term care? Okay, have you ever seen a patient who maybe has an infection but doesn't present with the kind of the same types of signs and symptoms we see in a younger adult? Yeah, what do you see maybe? Confusion, right? A lot of times I think about the UTIs, right? Patient has UTI or pneumonia, right? So instead of having what classic signs of an infection? Fever, chills, maybe all that, right? They're maybe more confused, okay? And that again might just have to do with the changes as we age. All right, so blood components. So we're gonna kind of focus on RBCs, WBCs, platelets. Talk a little bit about albumin. We'll talk about albumin more in the next unit. But our main concept is perfusion. Okay, what does that mean? We can have peripheral perfusion. We can have central perfusion. What do you think peripheral is?
Extremities.
Extremities, right? What does perfusion mean? Oxygen, yeah, to the extremities, blood, oxygen to those extremities, right? So that would be more of your peripheral. What about central? What's central then? Yeah, the heart, right? The organs, right? Okay. So there's different types of perfusion. So we'll talk a lot about perfusion, right? This whole semester, we're going to talk a lot about perfusion, right? Is the body perfusing? Is there good blood flow through the tissues, right? From the heart to the tissues. Okay. So we've got RBCs. Tell me about red blood cells. What do you know about them? Carry oxygen, right? That's their main goal, right? Carry oxygen. Okay, what else do you know about them? What do they look like? Kind of round, cone shaped, right? How long do they usually last? About 120 days. Okay, so those are important for you to carry oxygen. Okay, what about your white blood cells? When you think of white blood cells, what do you think of? Infection, right? Yep, they're going to prevent your protection. Those leukocytes, they're going to protect a client from infection. Okay, they help with that immunity response. What is immunity? What does that mean? We get vaccinations.
Preventing them infection.
Yeah, right. So what does that happens inside the body? How do you develop immunity?
You introduce it.
Yeah, you get introduced
Exposed.
to that virus or whatever it is, and your body makes antibodies against it, right? Okay, good. And then what do we know about our platelets?
Clotting factors.
Yep, so that's gonna help with our clotting, right? Our thrombocytes, our platelets, okay? They're very important when it comes to clotting. Okay, so we're gonna talk about different disorders when they become too high. Most often it's usually low that we'll talk about. But think about it, if a patient isn't able to carry oxygen in their red blood cells, right? Think about how they're gonna feel. Right? Who's got low red blood cells? What about if we have low white blood cells? Right? We know that they cause or they prevent infection. What happens if we don't have those that are working effectively?
Infection.
Infection. If we have clotting with our platelets and we don't have enough of them, bleeding. Okay, yeah, right. So think about what do they do? Usually we'll talk about when they're too low. Okay. And then what do you know about albumin? You heard of that? Yeah, helps to bring what? Yeah, helps to bring that osmotic pressure, so it kind of pulls fluid into the vascular space versus it leaking into the peripheral tissue, okay, into the tissues. So a lot of times with like a burn patient, they might have leakage of fluid. So we'll talk a lot more about albumin in our next unit. Okay, but that's also going to help that osmotic pressure of our blood. All right, so let's talk about red blood cells. Now, again, you don't have to memorize or know normals, okay? All the normals will be given to you on the exam, okay? And even on NCLEX, normal values are given. You don't have to memorize them, okay? They are on page 820 in your book that talks about normal ranges. Males and females are a little bit different on most of these, okay? Again, if you get an NCLEX question, it doesn't specifically state a gender, it'll just give you the whole range. So females are what is it, 12? 12 to 16 for hemoglobin, for females. Males, 14 to 18. So it would just say 12 to 18. Okay, so make sure you look at your normals on the exam so you know what normals are. Are normals on this book going to be different than where you work
Yes.
or where you go to clinical? Yeah. Okay. So what you might know is normal at your job might not be what the book says. Okay, so always look to see what your question is saying for normals. Okay. All right, so we talked about erythrocytes. Those are your red blood cells. They're going to carry oxygen. Okay. Again, you don't have to know normal count if you want to. Go ahead and look through it. Okay. So let's talk about kind of one of the most common ones that you'll see when it comes to low red blood cells. Okay. Low red blood cells, low hemoglobin, low hematocrit. Anemia. Are there a variety of different types of anemia? As you guys went through your reading. Okay. What did you notice as you went through your reading about key features? Meaning signs and symptoms, meaning what the patient is going to present with.
Fatigue.
Were they pretty much the same, every single anemia that you looked at?
Yes.
Yeah, pretty close, right? So think about that is when a patient is anemic, a low red blood cell, low hemoglobin, or hematocrit, you're going to present probably with the same type of symptoms. And you said 9, fatigue. What else? Think about what does red blood cells do? Pale. What about your respiration? Lower. Do you think they'd be lower or do you think they would be higher? If we
Higher.
don't have enough oxygen through our body, what does the body try to do?
Compensate.
Compensate. So we're going to breathe faster. Yep. So we'll breathe faster to kind of move that oxygen through. Okay. What else might a patient feel like? Look like? What's that? In sickle cell, they'll have pain. Yeah. Shortness of breath is a big one. Yep. Pale, fatigue, dizzy. Yep. Increased respiration rate. What about our heart rate?
Elevated.
It's gonna have to go up too. Why? Why, Logan? Yeah, right. Again, compensation, right? Trying to get more oxygen and blood throughout the body. Good. All right. So those are probably kind of similar for every single anemia, right? But as you look through there, you notice that there's a variety of different causes. Okay, so it could be a dietary cause. Iron deficiency. What else did you learn about that was maybe a deficiency in diet? Folic acid.
B12.
B12. Okay, good. Okay. What about blood loss? Could that be a cause?
Yes.
You lose a lot of red blood cells? Is that gonna cause you to have an anemia? Okay, what about a bone marrow disorder? Why would that cause me to have low red blood cells?
Just can't produce them.
Makes sense.
That's where your bone marrow, that's where your red blood cells are gonna start, right? That bone marrow. So if your bone marrow, you have dysfunction the way your bone marrow is, you may not have enough red blood cells, okay? And then genetic causes too. Such as sickle cell, right? Okay. So look at kind of what those signs and symptoms are gonna be for anemia. Look to see what are the causes, right? What causes it? So let's do a little case study here, kind of work through this woman here. So we have a 59-year-old who is admitted to the medical surgical unit for a suspected GI bleed. Okay, when you look at the patient assessment, she says, I've never had bleeding like this before. What caused it? Lately, I have been feeling so tired. Okay, so right away, what are you thinking here? I've never had bleeding like this. We don't know how much, right? Lately, I've been feeling so tired. What could
Anemia.
that be?
Anemia.
Could be anemia. What else could it be?
Just,
Life,
yeah.
right? Aren't we all tired? Like, who's not tired, right? Could be just life, right? But, you know, you're looking at what is the patient saying, right? Use that information. Let's look at our vitals. What about our temperature?
Normal.
Normal. Okay, what about our pulse rate?
Tacky.
Okay, so we're slightly elevated, we're tachycardic. Our blood pressure,
Low.
low, 90/54. Okay. One thing I will mention for NCLEX, right? When anytime you have a systolic blood pressure less than 100, you need to do an intervention, okay? Think about you as the nurse. Now, you might have a blood pressure of 90/50 and be fine. You might have a patient that you work with who has a blood pressure of 90/50 and that's fine, okay? In NCLEX world, when you're taking your NCLEX, anything less than 100, you need to be worried about that. Probably need to do some type of intervention, okay? Respirations of 22,
Elevated.
are they just slightly elevated?
Yeah.
Just slightly, yep. And then we have an O2 sat of 93% in room air.
Low.
A little on the low side, right? 95 or higher, okay? All right, so remember too, I will say this to you when you have me in clinical, you are responsible for the vital signs, okay? You are no longer the aide that takes the vital signs and hands them off to the nurse, right? You are the nurse, so you need to be responsible and think about, what am I gonna do with those vital signs? Do I need to do anything with those vital signs, right?
Yes.
Okay, that is your job. All right, let's look at the labs then. All right, our white count is 8,000. What are you thinking?
Normal.
It's normal, so we're okay there. Our RBCs are 3.5, or red blood cells.
Low.
Okay, those are low. Our HMH is 8 and 30.
Low.
Okay, those are both low. Low MCV. Do you know what that stands for?
It's low.
It's low, okay, it's small, it's microcytic. Okay, so mean corpuscle hemoglobin or volume, yep. Okay. So that's low. So we talk about these cells are gonna be small, microcytic. We also have low ferritin. What is that?
Higher.
Iron. Okay. So from that history, what the patient presented with, vital signs and labs, what are you thinking? Iron deficiency anemia, good. Is iron deficiency anemia common?
Yes.
Okay. Most common, right? This is the most common type of anemia you're gonna see, okay? Okay. And again, anemia usually isn't a diagnosis, right? It's underlying. There's some type of underlying problem that's causing this. Okay, so we have to find that out. And GI bleeding is a big cause of anemia that you're gonna see, especially in the clinical setting. You'll see a lot of patients who come in with acute GI bleeds. Okay, all right, so let's talk about a client who has iron deficiency anemia, right? Would you expect them to kind of feel tired,
Yeah.
fatigued, look pale? Okay. All right, let's look at our home medications. Levothyroxine, what medication what is that for?
Thyroid.
Yep, that's for thyroid, it's a thyroid replacement, okay? She's also on a multivitamin daily. And she's on ibuprofen, 800 milligrams orally every 4 hours for pain. What did we say ibuprofen was? What class of med?
NSAID.
NSAID, okay, it's on an NSAID. Are there any concerns there of the medications as you read through those?
Ibuprofen and bleeding.
Okay, ibuprofen, what about it?
Bleeding.
Side effect is.
Okay,
GI
side effects
upset.
of GI bleeding, okay? Conform ulcers and a patient can have GI bleeding, okay? So we need to further investigate that. Now, she takes 800 milligrams every 4 hours. Every 4, it doesn't say PRN, it says every 4 hours.
That's scheduled.
Too
So
high.
how much would she get in a 24-hour period?
1,200.
800 every 4 hours.
Oh, she would be getting 20. Wait. Yes, 2,400 milligrams.
How much?
800 times.
How many times is she taking it a day?
3,200.
It's a day, right?
3,200.
What's 8 times 6? 8 times 6? 48, right? Is that, am I doing my math right? Is she getting 4,800 milligrams a day? That was hard, you guys. It's really hard. We are struggling here. We gotta get our little.
It's 8.
out.
It's 8 in the morning.
It's Monday at 8. We don't do math. Okay. 4,600. 800. We write it down so I can't forget. Okay, 4,800 milligrams. If she's taking it every 6 hours, that's how much she's getting a day. What do you think about that dose?
Way too
Too
high.
high.
What does it say on the ibuprofen bottle? On the dose that you should take?
No more than 1,200.
Yeah, so usually take what, 400 is what you should take?
I think so.
They should. I know some of us take more. Should take 400 milligrams, so 2 of those. Okay. Every
6.
6 hours. Okay. So do you think that's too much?
Yeah.
Okay. A patient who has, let's say, osteoarthritis, rheumatoid arthritis, they may have a higher dose, right? So they might their dose might go up to 3,200 a day. Okay, which is a little bit higher than, maybe your 1,200 or your 2,400, okay? But this is quite a bit, okay? Could that be causing her GI bleeding?
Yes.
Okay. All right. So what do you think you need to do if she tells you she's taking that every 4 hours?
Consult the
What would be
provider.
your role as the nurse?
Consult
You need to educate,
the provider.
consult the provider, let them know that information. We might just have to stop ibuprofen completely,
Mhm.
right? Versus,
Or stop
Um,
NSAIDs just completely.
or what's that?
Or stop all
Or
NSAIDs.
stop all NSAIDs, yeah. Okay. So again, what else would you want to know why she's taking it every 4 hours for pain?
What pain is she
Yeah, what kind of pain
experiencing?
is she having that she needs to take it every 4 hours? Yeah, how long has she been taking it? Has it just been a day or 2, or has it been 6 weeks? Yep, that would be good information too. GI history? Yep, GI history. Has she ever had GI bleeding in the past? Yeah, absolutely.
Also, why is she taking the levothyroxine? It's a
Okay.
thyroid replacement. She could be experiencing the fatigue from that as well.
It could be from the fatigue from that too, right? So it's maybe her levothyroxine dose is not high
Mhm.
enough. Yep, okay, good. A lot of investigation. One thing you're gonna notice as your nurse, you're kind of a detective too, right? You have to kind of figure out how these all pieces fit together, what's going on with your patient. All right, she is complaining of headache and requesting pain medication.
Tylenol?
Would you want to give her some NSAIDs?
No.
Would you want to give her ibuprofen? Would
No.
I want to give her naproxen? Would I want to give her ketorolac?
No.
Would I want to give her aspirin?
No.
Could I give her acetaminophen? Would that be safe?
Yes.
Okay. When she says she has a headache, what else are you gonna ask her?
Rated on a scale of
Rate
1
it
to
on a
10.
scale of 0 to 10.
Drive it.
Describe it. What's the quality?
How long has it lasted?
How long has it lasted? When did it start?
Does it come and go?
Does it come and go? Good. What have you used in the past, right? What works, what doesn't work? All right, so your order then is to give her Tylenol 650 milligrams every 6 hours, I should say, for pain. Okay. Is 650 milligrams an okay dose for Tylenol?
Yes.
Yeah.
Acetaminophen?
Yes.
Average is either 650 or anybody else know what the other dose is usually? 1,000, right? Because you could, the acetaminophen tablets come either 325 or 500.
500.
Okay. No more than, what did we say?
4,000
4,000?
for healthy.
Yeah, for a healthy, good liver. Okay. All right, now we also have an order to transfuse a unit of packed red blood cells. Okay. Do you think that this patient, is it safe, do you think, to give this patient a unit of packed red blood cells? Does she qualify for packed?
Yes.
Yes.
Because what?
Low H&H.
Hemoglobin is low. And she might be actively bleeding.
Mhm.
Right? All right. So as you guys did your readings for your transfusions, tell me what you need to do before. You guys probably haven't got to blood administration for skills.
We started.
You started it?
Briefly, like
Okay.
we'll start tomorrow.
Okay, you guys will be good to go then. You'll impress Sandra with your, is it Sandra or is it Jill?
Jill.
You'll impress her with your skills here. Okay. Before you do a transfusion, tell me some things you have to do beforehand.
Vitals.
Vitals?
Ensure that the blood is compatible with the, like IV fluid.
Okay, before we even go get the blood,
Consent.
okay, a consent needs to be signed. Who does that consent?
You.
The provider can go through it and then we can witness it, have the nurse witness it. What does that consent say? Does anybody know?
It pretty much says, like, you're gonna get, or you're gonna get blood, and then it's asking, like, are you okay with it? These are possible side effects.
Yes, yeah. So talk about the risk factors, yeah, okay, and the patient has to sign it, yeah, so try that on file. Good, what else?
You double check that it's the right patient.
Okay, before you even get the blood, we haven't got the blood, we're just like, oh, we just got an order.
IV.
Okay, I have a consent.
You have an IV that's
Do you have an IV? And do you have an IV that's?
large enough?
Yeah, okay. They say 18. You can do a 20, okay? Probably not a 22, but an 18 or a 20 would work. Larger the better. What else? Yeah, type and screen, yeah. The lab will come up and type and screen. What information does that give you?
Blood type.
What blood type they are, right? Because we have to make sure we're giving them the correct blood type. Okay? So we have an order. We verified that the order makes sense. We have an IV. We typed in screens. We gotta wait for that. Anything else that we're forgetting? I know, to make sure I don't forget anything. Okay, we have all that. We're gonna go down the blood bank. We're gonna go get the blood. All right, we're gonna bring it up to the patient. Okay, then what do we have to do right before we give that blood?
True nurse verification.
2 nurses need to verify. What'd you say?
Check the bag.
Check the bag. What are you looking for in the bag?
Box.
Leaks? Oh, yeah, we don't want any holes in it. Expiration date, making sure it's intact, right? There's nothing, it looks.
Right
Make
type.
sure it matches
Floating
the
in
doctor's
it.
order.
What's that?
Make sure it matches the doctor's order.
Make sure it matches the doctor's order. Yeah.
Right
good.
patient.
What's that?
Right patient.
Yeah, so 2 nurses at the bedside.
Mhm.
We have to verify that we have the right patient, right? Look at the medical record. And we have to make sure that we have the right blood type. Okay. There's a good chart. See what page that's on here. About blood typing. Right, so make that up. Where did I see that? No,
It's in there.
maybe it's in the other chapter. I swear I looked at it. Oh, it's on page 823. It's in chapter 33. So back in the assessment piece. Talks about compatibility. Okay, so let's think about compatibility. What type of blood types are there?
Many.
many, right?
A positive,
A-
a negative.
B, AB, O.
O.
Yeah, okay. So those are the blood types, and then we also have to worry about what? You said positive, negative. What is that?
RH factor.
The RH factor. So you're gonna be positive or negative. Okay. So if you're negative, you can only get negative blood. If you're positive,
Cannot get a positive.
you can get positive or negative, correct? Okay. Who is the universal donor?
O neg.
O negative. What does that mean if it's a universal donor?
It can give to everybody.
Have you ever seen those medical shows? What do they say?
I need O neg.
I need O
stat.
neg stat. O neg means I need O negative, right? We're not gonna have time to type and cross the patient. We'll give them O neg. Everybody can get O negative, negative blood. Okay? What about AB positive? They're considered
Rare.
the universal recipient because they can get
Any
type of blood, right? Okay. Now, I'm A positive, A plus, obviously,
Mm.
right? That was my blood type, right?
me too.
I wouldn't expect anything other than A plus, right? Okay, so what can I get for blood?
A positive, O neg,
What blood can they give me? A positive,
A
A
negative,
negative,
O negative.
O positive, O negative, yeah, good. Okay. What would happen if you gave the wrong type of blood?
Transfusion reaction.
Hemolytic transfusion reaction, is that bad?
Yes.
Okay, so you need to double check to make sure, is this what the blood is? So if I'm A positive, yeah, and you're looking and you're like, well, the blood here is O positive, is that okay? Right?
Mhm.
Right, so I'm not always gonna get A positive blood, right? So you have to double check and make sure. Okay, so there's a good chart on page 823 for you to look through. Okay, 2 nurses at the bedside, you checked it, it's the right type of blood for that patient. What else do you need to do right beforehand you start it? Vital signs. Right, you need to get your baseline vital signs. Okay, you're gonna start that blood, and what type of tubing
Blood
you're
tubing.
gonna use, right? This is an example of blood tubing, okay? What, we have our blood, and what else do we have?
Normal saline.
Normal saline. What is the only fluid you can use with blood?
Normal saline.
Normal saline, okay? This is a filter, right? It filters the blood. And then this will go to the patient. So that saline is closed, right? While the blood is going through, the saline is closed because it has a roller clamp on it. So that after the blood is already all the way infused, then you would open up your saline and that would flush it through. Okay? So we hook them up, we use blood tubing, and we're gonna start up that blood. What do you need to do as that nurse?
Stay with the patient for 15 minutes.
Okay, why do we need to stay with a patient for 15 minutes?
Monitor for reaction.
To ensure there's no reaction, okay? Most times, if there is a reaction, it'll be within the first 15 minutes. Not always, most times, okay? All right, what are you watching for a reaction? What is a reaction? What are you looking for? Okay, change in temperature, good.
Back pain.
Chills? Skin changes? Like what? Rash, good. Anaphylaxis, what would you look for? Breathing, are they having problems breathing? Are they short of breath? Okay, what else?
Back pain.
Back pain? Okay, all right. If we notice anything out of the ordinary, what
Stop.
do you need to do?
Stop
Stop the infusion right away. Okay, good. Now what we usually do, take that down, put up some normal saline, just some fluids to keep them hydrated. Okay? You would also need to do what? Call the provider, get
Send-
vitals.
send the
Might have to
blood.
call a rapid response, right? Where you have other people come and help.
Send the blood back to the bank.
Yep, and send the blood back. Yep. All right, let's say everything went just as we planned. Okay. Okay, so let's go in first 15 minutes, no reaction. Okay, usually we'll start the blood, those first 15 minutes, maybe around 50 milliliters an hour, depends on the protocol of the hospital, right? We might start really slow. Okay, and then First 15 minutes, everything looks good, and we're gonna increase the rate. Okay, because
125.
the blood needs to go in within how many hours?
4.
4. Yeah, blood tubing is only good for 4 hours. Okay. So let's say I had, oh my gosh, we have to do more math. Okay. So I have 300 milliliters in the bag. Okay, in my bag of red blood cells. And I want it to go over 4 hours. What's my rate gonna be?
75.
Oh. It's good math.
Calculator.
Okay, somebody figured out in their calculator, okay? This is over 4 hours. Now, a healthy adult, 75 milliliters an hour, how much is that? Not that much, not that much, okay? Could I go over 2 hours?
Yeah.
Yeah, usually 2 to 4 hours is kind of the norm, okay? All right, so if I wanted 300 to go over 2 hours,
150.
150. You guys are
We woke up.
repeating yourself, okay? 150 an hour, okay? It just needs to be done within 4 hours, okay? Who of your clients might we have to slow down the rate? Elderly,
Children.
maybe children? What kind of underlying conditions, especially with the elderly, might they have that you have to be careful with? If we give them too much fluid. Kidney and what else? We don't want to fluid overload them. Their heart, right? Anybody who has like heart failure, kidney issues, we might need to keep it on the slower rate, okay? No, right? What if my patient is in trauma and the patient is bleeding out?
Wide
Am I
open.
gonna set that pump?
No.
You're just gonna open it up, right? Wide open gravity, get that blood in as fast. But in acute type of situation, you're gonna put it on a pump, over 4 hours. All right, been, let's say 3 hours. All the blood went through. You're gonna open up the saline. The saline is gonna flush it through and the blood is done. Okay? What do you need to do? Document what?
How much?
How much went in? Vitals? Are we doing vitals throughout the?
Yes.
Transfusion? Look at your protocol. It might be every half an hour. It might be every hour. Okay, so look at your protocol where you work. Okay, we're gonna document how much went in. We're gonna document vitals. Document the patient's reactions, right? Where would the blood go then when we're done?
Biohazard.
Biohazard bag, your red bag.
When we disconnect, we flush the-
Flush, yep, you could flush that when you're done. Well, the flush kind of takes care of that too, your IV bag, yeah. All right. Good. All right, just gave blood, good job. Now in clinical, you cannot give blood, but you can help. Okay, so I really encourage you to go with the nurse down to the blood bank, help with vitals, watch that part, but just go through mail, they don't let you do the blood. All right, any questions on blood? Good job. All right, so we talked about some reactions. Okay. Oh, no, these are talking about transfusion. That's the next one's reactions. So there are a variety of transfusions that you can give. Most common is going to be your packed red blood cells. Okay. Patient loses blood from trauma, right? From surgery, from a GI bleed. Okay, so red blood cells are pretty common. Okay, I'd say another common one would be a platelet transfusion. Okay, platelets are low. The patient's having some problems with bleeding. Okay, we can do platelets. Okay, platelets are a little bit different because they are pooled from a variety of different donors. So there's no real like typing that needs to be done. Don't have to worry about the same blood type. They also come with a filter, okay, that you would give it. And they're usually given over like 15 to 30 minutes. It's a lot quicker than you can get platelets. Okay. There's plasma. White blood cells are very rare. A lot of patients have a lot of reactions to them. So I would say the most often ones you are going to give are going to be your red blood cells and platelets if needed. All right, so reactions. Okay, we talked about watching our client for reactions. There are a variety of reactions, and there is a great chart on page 857 in your book that talks about different types of reactions, kind of the signs and symptoms, and what you need to do. Okay. Okay, so febrile. Okay. So kind of what it says, right? Febrile, what do you think the patient's gonna have? A fever, right? They're gonna have an increase, a change in their temperature. Okay, usually it's just like 1 degree, a 1 degree Celsius change. They might also have some chills, some headache. They could be having a reaction. So what do you need to do? We need to stop it, right? We need to stop it. Okay. Another one might be hemolytic. We talked about that, right? Hemolytic would be caused if you gave the wrong type of blood to the client. Okay. So again, they might have chills, they might have a fever, they might have dyspnea. Someone mentioned the low back pain. Okay. So that one, again, we want to stop it. Start some normal saline. Okay.
So even at a 1 degree change, stop it, right?
Yeah. I would stop it. I would assess my patient. What would you do with that information?
Talk to the
Yeah,
provider.
you'd call the provider and you would let them know, right? This is what happened. This is the change.
Mhm.
Do you want me to proceed? Sometimes they might say, give them some Tylenol. They might say, keep going, keep monitoring, or they might say, stop. What would I also ask my patient? What's that?
How do you feel?
How do you feel? Have you ever had a reaction before? Right? Okay. Sometimes if there's been a patient who's had maybe a slight reaction before, sometimes they might give them like,
Benadryl.
acetaminophen, they might give them diphenhydramine, like a Benadryl ahead of time to prevent it. Yeah. Allergic, it's another one. What do you think about allergic reaction? Not anaphylactic, but just more of like an allergy.
Around.
Yeah, a rash, right? We talked about skin changes, right? An allergy, they may just have an allergic reaction. It might be a rash, they might be itchy. Right? So we could do like an antihistamine to help with that. Now, if it's an anaphylactic reaction, a severe one, right? Patient might have anxiety, angioedema. What is angioedema? Facial swelling, right? Bronchospasm, cyanosis, that's a big one, right? What do we need to do then? Stop and epi, right? Epinephrine. Right, we need to make sure that that patient's airway stays open, bronchodilators, steroids. Okay. Bacterial, again, sometimes they'll have a reaction again, changing their, a fever, right? Fever, chills. Circulatory overload. This is what I talked about when you have that patient who has a heart failure or kidney issues. You give them too much fluid too fast. What might they present with? What signs and symptoms of iron fluid overload in them? Shortness of breath, chest tightness, crackles. Yep, increased heart rate, increased respiration rate, blood pressure, right? All that go up. Right, my patient might not be able to handle that. Okay, so what should I do?
Stop.
Stop. Yeah.
Might-
Sometimes if the patient isn't having a true reaction, they might say, slow it down. Or they might say, continue, finish the reaction as long as, or the transfusion, as long as they're doing okay. And then what would we give to get rid of extra fluid?
Diuretics.
A diuretic. Yeah. Can I give any medication through blood tubing?
No.
No.
Okay, nothing goes through that blood tubing except blood and saline, yep, normal saline. All right, good. All right, let's take our first break. Good job. We did a lot of math this morning, good job. All right, so let's flip back here a little bit to these, because I want to go through a couple of these. So we're going to go back to that first slide that talks about anemia. Okay, so we talked about iron deficiency anemia, but what about vitamin B12 deficiency anemia?
Not enough B12.
Not enough B12, right? Okay, right, so there is I guess on page 834 talks about kind of the common causes. You'll notice that this book law has a lot of charts, tables, right? If you didn't do Michelle review, she'll tell you, look at the charts, look at the tables, okay, key features. So vitamin B12 deficiency, right? So it could be lack of diet, or what else could it be caused by? What's
Failure.
pernicious anemia? Yeah, we don't have that intrinsic factor, right? Okay, don't have that intrinsic factor. And you'll also see a page on page 835, bursitis, which is kind of that beefy tongue, right? That you will also see in a client who has B12 deficiency. Okay, so if you are deficient in B12, how do you treat it?
And take more.
Injections or oral B12 or dietary changes, right? Okay, so another thing with this unit, every unit that we're gonna cover, dietary is also involved in it, okay? I highly recommend that you are going through and looking at a variety of food sources for, we'll talk about B12, folic acid. When we talk about food and electrolytes, we'll talk about calcium, potassium, sodium, magnesium, right? You need to have a variety of different foods that you know in each of those, okay? Because you guys didn't have a specific nutrition class, right? But NCLEX does ask about nutrition. I ask nutrition questions on the exam. So going back and looking at some of those foods that will be high in B12. Okay,
Hillary,
yeah.
I
yes.
did post, I don't know if everybody saw it, but I did put a nutrition table on there.
Awesome.
But
Where'd you put
just
it at? Resources or where was it?
announcements.
Announcements?
Announcements.
Oh, I didn't even see that.
But it's from my Saunders review, so just like, I put in the announcements, different sources, like, there's some common things, but there's some minor things. But like, always go back to Hillary or Iggy says it.
Right.
Oh, yeah, I see it.
Some announcements, okay.
Mhm.
I put lab values there too,
I see that.
and the same goes for that.
I kinda didn't look at my. Okay, so vitamin B12, animal proteins are big, fish, eggs, citrus. Okay, so kind of knowing those.
Leafy
Folic
green
acid
vegetables.
then. Lacking what?
Folic acid.
Right, not hard, see, this is not math, this is right, okay? So again, green leafy, citrus fruits, nuts. Okay, those would be kind of some of those interventions.
Green leafy vegetables.
Aplastic anemia, okay? Aplastic anemia, we've got issues with our bone marrow, so there really isn't any dietary there, right? We'll talk about that a little bit more here. I think I have a slide on that. Yep, I have a slide. G6PD, you guys don't have that one on your list here, but that is another one, and that's a client is just lacking an enzyme, not very common. Okay, and then autoimmune, what do you think autoimmune is? You think, if you ever heard that term autoimmune, what does that mean? Yeah, body's attacking itself, right? The body is making antibodies against itself. Okay. So those are a variety, but I just wanted you guys to know and look at some of those nutritional resources and look at what Michelle posted also. All right, so education, okay, if a client does have anemia, we talked about iron deficiency anemia. Okay, we can do a blood transfusion, but if a patient has long-standing anemia, what else are we gonna do for diet? Iron deficiency,
Iron.
okay? So we can increase our iron in our diets.
Supplements.
We could take iron supplement,
Yeah,
okay?
iron.
So tell me about iron supplements. So an oral iron supplement.
They're big.
They cause constipation. Okay, what else happens to the stools? They get kind of dark. Sorry, yeah, can cause some GI upset also when you take them. So what should you take them with? You take them with some food, right, will help. Okay, pretty common to be on a iron supplement. Okay, prenatal, what's that?
That's absorbed with vitamin C.
Yes, right, so taking it with vitamin C will help with absorption, right? Good. What about a child who can't take a pill? They might have to take liquid iron. What do you remember about liquid iron? They stain the teeth, so the child can take the iron with a straw. Yep. Okay. No. There are iron that can be given IV, intramuscular. Did you guys learn back in probably first level skills? Do you guys learn how to do Z-track? Remember the Z-track method? What was the point of that? Remember? Yeah, yep, drop it in there, kind of helps prevent staining of the skin too, when it comes to iron, because that can stain the skin. Okay, so that would be some changes with iron, an iron supplement or a multivitamin would give you iron. Okay, we talked about diet with folic acid, B12. Okay, what do you know about milk intake for infants and toddlers? Talk a little bit about pediatrics here. Infants are up until the age of 1, right? Toddlers would be 1 to 3. So up until the age of 1, should infants be taking cow's milk?
No.
Right? They'll get their iron from breast milk, iron fortified formula, cereals, okay? What about if we give a baby, a child or an infant, whole milk before they're a year old? What can happen? You know? They aren't able to digest it, okay? Can cause actually some bleeding too. It can cause some GI bleeding, okay? Do we want our child to be bleeding?
No.
Okay. After that, after a year of age, children can take whole milk. Okay, whole milk helps with brain development. These are the good fats. Okay. What about milk in the toddler? Yeah, too much prevents iron absorption, right? Some kids love milk, like they're having a sippy cup with them all the time, right? But is milk a good sense of a good source of iron?
Mm-mm.
Okay, so they can become iron deficient if they're drinking too much milk. They're not taking enough of the other foods that are high in iron. Okay, so those are some of the pediatric considerations to think about. Okay. Iron supplements we talked about, and then transfusions, again, could be an intervention. If the hemoglobin. All right, good. Let's talk a little bit about sickle cell. Okay, what triggers a patient to have a sickle cell crisis?
A lot of things.
Temperature changes,
Dehydration.
elevation changes, dehydration, hypoxia, good. Exercise, infection, smoking, stress. Right, a whole lot of different things causes a client to have a sickle cell crisis, okay? Normal hemoglobin up top there. A client who has more S, okay, hemoglobin S, can develop what we call these sickle cells that become misformed, misshaped, and then what happens here? Clump together, and what happens?
You can't get oxygen.
Okay, can't get oxygen to where? Tissues, the organs, right? You can kind of form those spots and those blood vessels.
Perfusion.
Okay. All right, so a client who has sickle cell disease doesn't mean they're always at a crisis, right? Okay, it's genetic. Okay. But when they develop a vaso-occlusive crisis, right? So episodes of where they have more sickling, usually is a sudden onset, right? Crisis is a sudden onset. Patient's gonna complain of what?
Pain.
Right? Okay, with that vaso-occlusive crisis, they're gonna have pain, right? This vaso-occlusive event, right, is when they have those red blood cells that are sickling more that are gonna cause blood flow to be either blocked or decreased. Okay, so a patient who has a vaso-occlusive crisis is gonna complain of pain. Okay, that is the most common symptom of a vaso-occlusive crisis. Okay, do you think that these clients who have sickle cell usually have some sort of anemia going on?
Yes.
Okay, what do you think happens to the anemia when they have a crisis?
Good.
It's gonna get worse, right? The numbers, their hemoglobin, factor, red blood cells are gonna be decreased. Okay? Over time, a patient can have a variety of different complications, right? We might have some joint damage. Okay. What about acute chest syndrome? What is that? What did you learn about acute chest syndrome?
It's a life-threatening condition.
Okay, it's a life-threatening condition, yep.
It's usually associated with respiratory infection
Okay.
and can be caused by fat embolism and debris from sickle cells.
Yeah, so a patient can have a vaso-occlusive crisis, right, having some pain, but we also may have some issues with the chest. So we think about acute chest syndrome, right? Think about some of those signs and symptoms that you might see like with a pneumonia, right? It's often kind of looks like a pneumonia. So a patient might have what?
Cough,
Cough,
shortness of breath,
shortness of breath, right? Might have some crackles.
possible fever.
Possible fever, yep. So it almost looks like a pneumonia, right? We got some of those sickle cells that are happening within the chest cavity. So those sickle cells are gonna block kind of those lung vessels, those lung blood vessels up here. Another complication that you might see in a client who has sickle cell is acute sequestration crisis. And often that happens in the spleen. Okay, so we have sickled red blood cells that get trapped in the spleen. Okay, if they get trapped in the liver or in the chest or in the lungs, we might have an acute chest syndrome. But often it gets trapped within the spleen, okay? And that spleen fills with blood, okay? And it can be painful, right? Okay, the patient's gonna have pain. The patient's gonna have increased left upper quadrant pain. They might have that spleen that becomes enlarged. You may also have a decrease in your hemoglobin hematocrit, right? An increase. So the patient again might be more fatigued, more pale, more short of breath, more dizzy. So all of these can happen when a client has sickle cell and then maybe has a sickle cell crisis. Okay, so a patient who would come in, we're looking at their labs. Hemoglobin S. Hemoglobin S is what's kind of one of those key features you're going to see if you would do a blood draw, and that's going to be elevated in a client who has sickle cell. Okay, it's a very low in the rest of us, but a client who has sickle cell is going to be very high.
It's about 80
That
to
would be something
100%.
you could see in a patient who has sickle cell. What do you think about our hematocrit level? High or low? Low.
Low,
What do you think about our reticulocyte count? What is a
elevated,
reticulocyte?
immature red blood cells.
Immature red blood cell. Okay. Do you think it'd be high or low?
High
Why?
because of the short lifespan of the red blood cells.
Okay, the short lifespan, what else? What does the body want? More oxygen, so the body's gonna make more red blood cells, and they're gonna push out those immature red blood cells. Okay, so you're gonna see an elevation in that. What about our total bilirubin? Do you think that'll be increased or decreased?
Increased
Increased. Why is that gonna be increased? We have some breakdown. If that cell is getting more sickled, right? It's gonna lose its shape and it's gonna leak some of that bilirubin, okay? And that bilirubin is gonna be into the bloodstream. Yep, so the destruction of those red blood cells. Good, okay? So that might be some of those lab values that you're looking at. They notice some changes. Okay. So pain. Pain is a big problem, right? A 10-year-old with sickle cell crisis is admitted to the pediatric floor in a vaso-occlusive crisis. Okay? Patient has pain. Joint pain at a 10 out of 10. What do you think? Is that severe pain?
Yes.
10-year-old, what kind of, if you think about a competent, normal developed 10-year-old, what would be a scale we could use? Pain scale.
0 to 10.
Yeah, 0 to 10, that numerical scale. PCA is ordered for this client to care for their pain. Do you think that's appropriate?
Yes, if they are mentally competent.
Okay. What education needs to be completed? Mackenzie in the back. What education needs to be completed with your patient and the family before a PCA?
If you have pain.
And if mom and dad or sisters in there, can they push the button?
No.
Just the patient. And what if the mom says, well, I don't want my child to overdose.
They
So I'm
can't.
only gonna have them push the button every hour.
They can't.
Can't overdose. Kayla, how would you explain that? How they can't overdose?
I would tell them that a pump is set to like a set dose and it like maxes out. So. I mean, they'll get a certain amount of medication each time they press the button.
Yes, good, but they can't overdose. Good. All right. What about other interventions for pain besides maybe an opioid or PCA? Distraction, yeah. 10-year-old, how can we distract a 10-year-old?
Tablet.
Video games, TV, iPad, and electronics, right? They're good. Okay, what else? What else would a 10-year-old maybe like? Music. Music, that'd be a good one. Music.
Could include
So
low.
those are
stim-
interventions that we could use. What needs to be monitored when a patient is on
Respiratory rate,
respiratory rate, right? What else?
pain levels.
Pain levels, sedation levels, which is mental status. Yep, absolutely, your sedation. Okay. All right, so, oh, I forgot we have more math. All right, so PC order, we're gonna initiate morphine PCA. The basal rate is gonna be 0.02 milligrams per kilogram per hour. Okay, our weight is 84, so let's change our weight from pounds to kilograms, and then we're gonna round it to the tenths place.
8.2.
38.2 is our weight,
Yep.
okay? And now we're going to figure out our basal dose, and let's round that to the hundredths. Our basal dose is 0.02 milligrams per kilogram per hour.
0.76.
Okay, so that, when I say a basal of 0.76 milligrams per hour, what does that mean?
That's what they're gonna get.
Just that, right, they're gonna get that every hour, they're gonna get that amount, okay? Now, our intermittent dose or our demand dose is 0.035 milligrams per kilogram. Sorry,
Max 8 milligrams.
does it say max of 8?
Yes.
So what would be our every 10 minutes? We're gonna round that to the tenths.
1.3
1.3 milligrams per
kilo. No. 10 minutes.
10 minutes. Okay, so they get 1.3 milligrams every 10 minutes. Okay. Okay, now we have to do more math. Right, so in an hour, what is the max amount they can get, including the
other one.
including the other ones? Including the basal and the demand.
8.6.
Oh, we're a little high then.
Mhm.
Not very well.
8.6?
Mhm.
So we took 1.3 milligrams every 10 minutes, so times 6, right? And then we added 0.76.
Yeah, 8.56.
We're over.
Mhm.
Better change that tonight. Okay, we're gonna do max of 9. What does that work? Are we okay?
Yes.
Max of 9. I'm gonna change it. So is it your responsibility to figure out that they're not getting too much?
Yes.
Okay, what are you assessing? To make sure that they're not getting too much?
Sedation.
What does that mean though? What are you assessing? You walk in. Right? Michelle's laying in bed, mouth open, drooling. You know, and I do too, I do. And I shake her and she, maybe getting too much?
Yes.
Yeah, right? What if the patient's complaining of so much pain, 10 out of 10?
Talk to the doctor.
What else could you do?
Other pain
Yeah,
medication.
think about other pain medications. Is there any other, maybe non-opioid that we could do? Is there any other interventions that we could include? Good. Yeah. Yeah, that's interesting. All right, so when it comes to a patient who has sickle cell, the thing to remember that I always like to remember for interventions is HOP. Okay, doesn't always have to be in this order. But what does HOP stand for? What does the H stand for? Hydration. What does the O stand for?
Oxygen.
Oxygen and P,
Pain.
pain. Usually those are gonna be some of your priorities. Doesn't always have to be in this order. Okay, one thing I will say throughout this whole term, pain is important. Pain is our first unit that we're gonna talk about. But is your patient gonna die of pain?
No.
Probably not. Are they gonna die of an oxygen level of 70?
Yes.
Are they gonna die of a heart rate of 30?
Yes.
Are they gonna die of a fever if it's really high and they're neutropenic?
Mhm.
Yeah. Okay, so always remember that too, right? Remember, think through your ABCs. Airway, breathing, circulation is always gonna take priority, right? Pain's pretty high up there on how we're gonna treat it. Right, but I wanna treat my patient who has other problems. Hydration. Okay. IV fluids, oxygen, pain medication, right? We talked about IV analgesics. Okay, we can also include some non-pharmacological interventions. Hydroxyurea. That was one of your medications on your list for today. Tell me about hydroxyurea. Can be given for a variety of different disorders that we'll talk about today. Yeah, increases the fetal hemoglobin, which helps with what? Reduces sickling, so keeps that red blood cell within that normal shape. Yeah. So client to have sickle cell, maybe usually frequently sickle cell crises, might be put on hydroxyurea, right, to help decrease the amount of times they have a crisis, to help the red blood cells stay in that good shape. What's the side effect of it though? What's that? Birth defects, yep, so taking it when a woman is pregnant. Yep, what else? Yeah, neutropenia, it can be used as a chemotherapy agent, right? When you think about a chemotherapy agent, what does it do to your bone marrow? Suppresses it, okay? So patient could be at risk for infection, okay? Might even be at risk for more anemia, might even be at risk for more bleeding, right, if it suppresses all of that, okay? Also can, sometimes nausea and vomiting can kind of occur with that also. Okay. So hydration, another one, giving IV fluids. Okay. Giving oxygen if needed. So think about it, if a patient comes in and a cause of it, a trigger of it is hypoxia. Oxygen, okay? A patient comes in and a cause of it is dehydration.
Fluids.
Okay? If a patient comes in and they have an infection.
Infection. Treat it.
Yeah, so it might be antibiotics, it might be fluids, it might be oxygen. Okay? Pain control. Okay? If they come in because of blood loss, right? Fluids. Pain control. Okay, so those are kind of your main Your main focus is gonna be on those interventions. Is there a way to prevent sickle cell?
No.
Okay. To prevent the actual disease, no, right, because it's genetic,
Mhm.
right, but prevent that patient from developing sickle cell crisis, vaccinations. Avoid the triggers, right? Think about those triggers, avoid the triggers, keep that patient up to date on vaccinations, absolutely.
Avoid alcohol and tobacco.
Okay, yep, smoking is a big one. Tobacco, healthy lifestyle, right? What are those triggers that that patient has that put them in a crisis? And educate them. Okay? We want good tissue perfusion. Okay? The client has sickling, they're not gonna be perfusing well. Okay? To the peripheral, to the organs. How do you know we have adequate tissue perfusion?
Checking cap refill.
Okay, cap refill, who else? O2 stats, cap refill,
Pain assessment.
pain assessment. What else do I check on head perfusion?
Pulses.
Pulses,
Color.
cap refill, color. Temperature, yep, good, all of that. Right, am I perfusing well? Does the patient have pain? Is that pain gone down? Right, are they perfusing well? Good job. All right. Here's a question for you. I'll give you some time to read through it. Pick your answer and then we'll talk about it as a group. The child in a sickle cell crisis is admitted to the hospital, experiencing severe pain, abdomen, hands, and feet. To reverse the crisis, which action would the nurse perform as priority? All right.
Do we
So
know
what is the
anything else?
question asking us? What is the question asking?
Priority.
To reverse. Okay, to reverse. What are you gonna do to help reverse the crisis? What'd you pick?
D.
Is it gonna prevent it?
No.
Right, they're already there, right, they already have the crisis. But to reverse it, what did we say what a patient might need?
Hydration.
Hydration. Okay, is giving pain medication important?
Yes.
Is it gonna reverse the
No.
crisis? No, it's gonna help with the pain, right? Good. All right, another type of anemia, I just want to talk about very quickly, aplastic anemia. With aplastic anemia, there's not enough red blood cells to do damage to the bone marrow, right? So this one damages the bone marrow and can also lead to pancytopenia. All right, what does pancytopenia mean, Mary? Do you know? Yep, all blood types. All blood types are low. So our white blood cells, our red blood cells, our platelets, they're all gonna be low, right? Because our bone marrow is not functioning like it should. Okay, anywhere from moderate to severe complications. Okay. Usually the only cure for this is a stem cell transplant, right? Because the bone marrow is just gonna keep on not working like it should. So patients usually have signs and symptoms of anemia. They might have some infections. They might have some bleeding, right? If all of those are low, all those blood cells are low. Okay. So stem cell transplant might be done. We also might give some growth or bone marrow stimulants to help. Okay. What are some of those growth stimulants, blood stimulants that we can give to help our patient? There are two specifically one's for red blood cells and one's for white blood cells. We'll give these to help that bone marrow stimulate and produce more. What were those meds that you looked at for today? Which one?
Colony.
Nope. Yeah, they got the colony stimulating factor. What are that? Someone say? Yeah. I don't think I spelled it right, did I?
Will ask autocorrect.
I didn't, did I? That's really bad.
It's just a page, not actually a page. But otherwise,
EPOETIN.
P-O.
ETIN.
It's fine, give me credit, okay? Epotin, alpha, is going to increase what? Red blood cells. Erythropoietin is what? Have you heard of that? Erythropoietin. It is a hormone that produces red blood cells released from what body? Kidneys. The kidneys produce erythropoietin, which helps to stimulate red blood cells. Who has kidney problems? Who won't produce enough erythropoietin? Chronic kidney disease. Chronic kidney disease therefore has what? Anemia. Right? Erythropoietin helps to stimulate red blood cells. If we don't have it, we can develop anemia. This is a synthetic form, right? Tells the body to make more red blood cells. What's the one that we use to make more white blood cells? Yeah, what's it called? Go grasp them. White blood cells, also known as leukogen. I don't have enough white blood cells. I'm gonna give a synthetic form, hopefully my bone marrow will make more of them. All right. Another form, hemolytic anemia, we talked about this one, right? This is when a patient possibly has the wrong blood type. Okay? Wrong blood type. So blood transfusion. So the patient can have, right, maybe some of those hemolytic reactions. And lower back pain, right? Sometimes they even have that impending doom, right? We want to make sure our patient doesn't have that impending doom. All right. All right, so I've talked enough about anemias, right? So that was all the anemias. I'm trying to wait too long. Okay, so not enough red blood cells, not as good hemoglobin. Now let's talk about one thing that can happen when we have too much. Okay. Number of RBCs is greater than normal. Hemoglobin is greater than normal. Hematocrit is greater than normal. Okay. Polycythemia vera. Poly meaning what?
Multiple.
Many. Okay. Cythemia. That means cells in the blood. Okay. So we have too much. It's the cancer of our red blood cells. Okay. It can be acute or it can be chronic. So what happens to our blood? It becomes hyperviscous. What does hyperviscous mean? Yeah, thick. Okay. So think about that. If my blood becomes thick, what am I at risk for? Hot. Absolutely. Right? Okay. So we have an increase in our red blood cells. Often what happens also is they also have an increase in white blood cells and platelets also. Okay. So we have hypercellularity, which means a lot of cells, right? Or too much cells, excessive amount of cells. Okay, so my blood is very sluggish, hyperviscous. How is my oxygen going to be? Right? Okay, poor gas exchange. Am I more at risk for clotting? So what do we do for these clients? Phlebotomy is a big one, okay? Depending on the patient, they'll go in and have blood removed. right? We talk about phlebotomy as getting our blood drawn, right? They're removing maybe a liter of blood or more, okay? Depending on the patient, they want the hematocrit around 45%. That's kind of what the goal is for most patients. Hydration, why would hydration be important?
Then to like,
Getting that blood out, right? Make sure it's not so thick. How do we increase the venous return? Right, think about my Lordstrom is, how do I get that blood back up?
Elevation.
Elevation, what else could I possibly do? Permission back, yeah, elevation, right? To help that blood help back up to my heart, because what happens if all this blood is pooling down my lower extremities? Edema and DVTs, right? Yeah, good, DVTs. We can have some thrombus that forms. Okay, so again, hydroxyurea, we talked about already. That can help with this medication. It kind of slows the growth of those new cells. Okay, and aspirin. So low dose aspirin, how many milligrams is a low dose aspirin? 81. Okay. So low dose aspirin can help prevent, right? So it's an antiplatelet. So it's gonna prevent left clotting.
okay.
So we don't want clots to form. Is this client more at risk for strokes than MIs?
Yes.
Absolutely. All right. One childhood, I guess anemia that I want to talk about also is thalassemia. Okay, this is another type of inherited type of anemia. And again, this type of anemia, they don't produce a normal hemoglobin. Okay? Therefore, they don't have a healthy red blood cell. Okay, so the bone marrow is going to produce less healthy red blood cells. So over time, these children can have anemia. Think about the signs and symptoms we talked about with anemia, right? Dizzy, cold, pale, okay? These children might have growth issues. And they do have some changes in their facial bones, as you can see here. And that's due because the bone marrow kind of expands and widens and actually causes some facial deformities that can occur. Okay, so with these children, treatment is red blood cell transfusion. They're going to need multiple transfusions. Okay. But what can happen if we give too much red blood cells? We can have an increased amount of iron. And if we have too much iron in the blood, the patient again can have abdominal pain, they can have weight loss, joint pain. So we can do this chelation therapy. What does that mean? What do you think that will do? Manage the overload, that iron overload. The ferroxamine is one of the medications I think was on your list for today. Okay. That'll help to remove some of the extra iron that this child would get because of those common or those frequent red blood cells. Next question. Which child is most likely to have iron deficiency anemia?
Too much milk.
Yeah, too much milk, right? Instead of too much milk, they're not taking in enough iron, fortified foods, or foods high in iron. Wrong blood type, what did we say was that type of reaction? Hemolytic, yeah, and then a sickle cell crisis. Right? Okay. Good. How else do we get iron deficiency anemia? Gastrectomy, yeah, would that be B12?
Oh, that's B12, sorry.
Yeah. How about iron deficiency? Well, what else did we say? Who was our client? GI bleeding.
Alcoholism.
GI bleeding, trauma, right, whenever we're losing that extra blood and iron, yeah, good.
The
All
book,
right.
the book also says a partial gastrectomy.
Does it?
Mhm.
Let's put
For
the-
both iron deficiency and B12.
Okay. All right, so white blood cells, so we talked about red blood cells, let's move on to white blood cells. So these are leukocytes, right? They're gonna protect us. Infection, inflammation, they're important with allergies, cancer. Okay, again, you don't have to know normal, 5 to 10,000 is normal, maybe you've learned about that, but again, that's something that you have to remember. Okay, so again, they're formed in the bone marrow. If there's too few, right, too many, it can be an issue. Okay, so I want to talk about a left shift. Have you heard of that term before, a left shift? You might see this if you go to clinical and you're reading through the doctor's notes, you might see somebody has a left shift. Okay, so sometimes it's called a left shift, sometimes it's called bandemia. Emia meaning what? What is emia? Like anemia. Blood, right, in blood, right? So left shift, so band would be more bands in the blood. Okay, so this is when you will see, this indicates, if you see what we call a left shift, it indicates that the bone marrow isn't producing enough mature neutrophils. Okay, what do neutrophils do? We have some type of foreign invader. Body
They
sends neutrophils
attack.
over. They attack and eat up that invader, right? Kind of there's that phagocytosis. Have you heard that term? Yeah.
Are you just able to say again what left shift is indicates that the,
Bone marrow's not producing enough mature neutrophils.
thank you.
Yep. Okay. So if you look at the top there, you will see that the bands are about 3 to 6%. And our neutrophils are also known as SEGs, are 50 to 62%, okay? So your neutrophils, your SEGs, those are your mature neutrophils, okay? SEGs are mature neutrophils. They can fight infections, do that phagocytosis. Your SEGs, or your bands, excuse me, your bands are immature. So do you think immature neutrophils are gonna have that phagocytosis? No, okay? So on the bottom, you can see what's called a shift to the left. What do you notice about your bands? They're increased, okay? So you have an increase in the number of immature neutrophils, okay? This is a big indicator that the patient has a bacterial infection. You can sometimes see it in inflammation too, if it's a very severe inflammation, but it usually has to do with a bacterial infection. Because what is the bone marrow trying to do?
Fight it.
Fight it, right? So they're pushing out as many white blood cells as I can, but it's pushing out bands. And these bands are immature. And these bands aren't going to be able to fight that infection. Okay, so if you ever see that in a patient's or doctor's notes, shift to the left, look to see if it has to do with an infection. Is your patient here for an infection? Okay, why is it called a shift to the left? It has to do with the cell type and where it is in the maturation. I think this was in the 80s. I think this is them. Does anybody have the piece of one? Yeah. I think I saw like that.
Whatever.
Thank you. Sometimes I'm like, did I dream that or did I really read that? Maybe it's in a notebook. I don't, five, maybe it's in an old book. Okay, but basically a shift to the left means that in the maturation process of that neutrophil, it's not yet. It's not yet normal, right? So that's why it's a shift to the left, meaning it's to the left of the maturation process, if that makes sense. And it's not. It was in the old book I saw it. Okay, all right, so shift to the left, more bands. Bands are what? Immature. Segs are
Mature.
Okay, all right. Let's take a break. It's 10 o'clock. Let's come back at 10 after and we'll start with our white blood cell disorders. That's what I do. Somewhere, okay? If you don't have your book with you, that's fine. Just jot down page 322 so you can look at that in your book. It's back in the immunity and inflammation. And it just talks about the maturation of a neutrophil, right? So the seg, right? The seg is the mature, and if you go to the left of it, right, that's the band, right? So it's not quite mature. So it's kind of like this is the pathway of how a cell, how that neutrophil is made. Okay, so it starts out as a stem cell. Ooh, here's my lottery ticket.
Did you win anything?
The scratchers,
On anything?
$5.
Mm.
You know, not the 30,000 like I thought it was gonna be. Okay, so it starts as a stem cell, right? And then another cell that we're gonna talk about is the next cell is a blast, a myeloblast cell. Okay, we're gonna talk about blast cells here next. We talk about leukemia. Okay, blast cells are different than bands because blast cells are more, they're kind of a step up from a stem cell. So they really haven't figured out which pathway they're gonna take, right? Because a stem cell can go as a red blood cell, a white blood cell, or a platelet. Okay, so these blast cells haven't really, they're even less mature, right? They're very mature. They're not really have a function. Okay, so if you look at that picture on page 322, you can kind of see how the maturation is.
It's 311 for the old book.
Okay, 311 for the old book, thank you. All right, so let's talk about leukemia. Okay, so leukemia is an uncontrolled production of immature white blood cells. Okay, it's a type of cancer, right? It affects the blood cancer, okay? It affects the blood. So it's an uncontrolled production of immature white blood cells, but these are the blast cells. Blast, okay? They're the precursor to all cells, meaning all cells are going to start out as a blast cell, okay? So blast, right? We're talking about leukemia. And band, we talked about what? What were those band cells? Where do we see that in?
Left shift.
Yeah. usually
Bacterial.
infection. Yep. Okay. All right. So all of these extra blast cells get formed in the bone marrow. Okay. So then what happens to the bone marrow? All those blast cells are being formed in there. What do you think happens to the bone marrow? Yeah, it's overcrowded. And what else does the bone marrow do? The other cells, yep, the red blood cells and the platelets. So do you think those are going to increase or decrease?
Decrease.
Those are going to decrease. Okay. So is that patient going to be at risk? How they present then? Meaning how will, if they don't feel well, they come to the clinic, what might they feel like? Okay, tired. Yep, low oxygen due to the low red blood cells. What else have they noticed? Easy bruising. Petechiae, right? From the low platelets. Yeah, nosebleed. Yeah, epistaxis. Nosebleeds.
Is there pain with this?
Yeah, think about the bone pain. How people have bone pain? Fevers, right? If they don't have enough white blood cells,
Can't fight that
they
infection.
can't fight infections. They might be having frequent infections. Our infections just can't get over it. There's also in your book, it talks about 840, talks about kind of the signs and symptoms that you might see. We just talked about, right? Echinosis, petechiae, bleeding gums, weight loss, joint pain, bone pain, headache, fever, a variety of different symptoms they might feel like. Diagnosis, right? The best way to diagnose this is going to be a bone marrow aspiration and biopsy. What is the difference between an aspiration and a biopsy? Yeah, aspiration is drawing out the fluid in the bone marrow. What is a biopsy?
Isn't it like actual like procedures, like surgical procedures?
Yep, they actually go in kind of with a hollow needle and like kind of punch out a little bit of that bone marrow. Okay, that is a definitive test. That is how you're gonna look, right? Pathologist is gonna look under the microscope to see, are there blast cells? Okay. What is that information then gonna provide? Why do we do a biopsy? What's it gonna tell us?
Type.
Confirm type, yep, the type of the cancer and confirm that it is, yes, it's a diagnosis. Okay, so again, think about those levels that are lab levels, right? Our CBC, like our H&H is gonna be low, our platelets are gonna be low. The white cells, they could be normal, they could be low, or they could be high. Okay. But your blast cells are gonna be increased, right? Those immature. Now, your book talks about a variety of different types of leukemia. There's a chart, I know that in the new book, page 839, there's ALL, AML, CLL, CML. You do not need to know the specifics for each of those, okay? We're just gonna talk about leukemia as a general overview concept, okay? So don't spend your time going, okay, what are the characteristics of this? What's the treatment? Because it's all kind of the same. I just want to talk about leukemia in general, okay? When a client has leukemia, right, the things I want you to be concerned about is protecting them from infection, right? Protecting them from injury and fatigue. Those tend to be the first kind of problems to deal with, right? Infection, injury, fatigue. Those are what we're going to focus on, okay? Now, ALL, again, I'm just going to briefly talk about each one, right? This is most often you're going to see in children. Children get this type of leukemia. What is the A? It's acute, right? There's acute and there's chronic. Okay. So acute means what? Symptoms come on quickly, right? Chronic might be longer, right? And then lymphocytic or myeloid, it just depends on the pathway that it follows, okay? Again, very general, okay? So infection, injury, fatigue for all of these, right? So we have ALL, we have CLL, that's more chronic, you'll see in adults. We have CML, okay? But what I want to focus on is infection, okay? Protect the client from infection, okay? We talked about them being at risk for infection because of low white counts, right? Okay. How do you protect a client who maybe is going through treatment or maybe going or just has a low white count? How are you going to protect from infection?
Hand washing,
And precautions if necessary.
What kind of precautions?
neutropenic.
Just,
Yeah.
like,
Neutropenic precautions? What does neutropenic precautions mean?
Masking
Yeah, masking, hand washing. Who am I protecting?
them
Why am I wearing a mask?
to protect from our,
Right, they're not infectious, right? But I could be, right? So I'm protecting myself. I'm protecting them from me, right? So I'm gonna wear a mask. Okay, what else would you do for neutropenic precautions? Hand washing is very big. What else? Okay, fresh flowers,
With visitors.
limit visitors. Why not fresh flowers? Bacteria. Yeah. Yeah, what about the foods?
No raw.
No raw foods? Okay, standing water, right? The flowers could have standing water, no humidifiers, no cups of water that just sit out for hours and hours, like that can all grow bacteria. Okay. How do we assess for infection for our client?
Temperature now.
Okay, so we're looking at vitals, we look at temperature. Where else might they have an infection?
Wound.
Okay, they have a wound infection, so we assess any wounds. Where else do they get an infection?
Respiratory tract.
Yeah, respiratory tract, right? Do you have any crackles, any fevers? Where else? Okay, so GI. Where else? Bladder, yeah, GU, that's a big one too, your bladder infection, right? We're looking for any signs and symptoms of infection, any changes in urine output, color, and looking at the wound. Doing cultures if we suspect that the client has an infection. We want to keep their skin clean, right? So usually bathing daily, right? Preventing infections, coughing free. If I bring any equipment into the patient's room,
Leave it.
yeah, we leave all the equipment if we can, right? Stethoscopes. Machines, whatever you can. All right, what about protecting from injury?
Full risk.
Fall risk, why is the client at risk for a fall? Weak, dizzy, yeah, from the anemia, and what else?
Medications.
Okay, maybe medications that we're giving, yeah, pain medications, other medications. What about fatigue? Why is the client at risk for fatigue?
Anemia.
Anemia, yeah, okay. How do you treat fatigue? How do you help that patient conserve energy?
Remote rest.
Promote rest? What about you as a nurse? Good diet?
Assist with
Assist.
ambulating.
We need to, right? Cluster care maybe, right? Okay. And to think about those, kind of those main interventions. When a patient has or when a patient has leukemia, what kind of treatments are available?
Chemo.
Okay, chemotherapy, radiation, or stem cell transplant. Yeah, okay. So tell me a little bit about chemotherapy. Kills all the cells, right? It kills fast-growing cells, which are cancer cells, but they also can kill our healthy cells, right? Fast-growing cells in our body are what? Your hair, yep, GI system, okay? So a patient who gets chemotherapy, sometimes they'll lose their hair, right? Sometimes they have some GI issues, they might have mouth sores, might have diarrhea. Okay, not everybody, right? Depends on the treatment. Okay. We have to watch for that. Okay, what about radiation? What happens with external beam radiation? Yeah, skincare is so important, right? Because what can happen to the skin? It can break down and it can look like a really bad sunburn, right? So we gotta take care of our skin. What goes on our skin?
Sunscreen.
Nothing unless the provider orders something. No creams, no lotions, nothing should go on that skin unless the provider orders it. How do you take care of it then?
Washing.
Yeah, mild soap, right? Just protect it like you would a sunburn, right? Hot showers, go out in the sun,
Mm-mm.
right? Have you ever had a really bad sunburn? It hurts, right? Okay, what about stem cell transplants? In a stem cell transplant, that could be another intervention for leukemia.
Is that where you're taking the cells out and replacing it?
Cells from who?
A healthy donor.
Okay, so it could be from a donor. It could be from yourself, the patient, or it could be like from a twin or a sibling like that. Okay, so we're taking the cells out, stem cells, right, from a donor. Making sure if it was from yourself, autologous, right? If it's from yourself, make sure that those stem cells are healthy, right? Okay, and before the patient would get a stem cell transplant, what happened? What do they receive? Okay, non-immunosuppressants, kind of, but what are they gonna give to kill off all those cancer cells? Radiation and chemotherapy, right? So they're gonna get high doses of chemo radiation because we wanna kill everything in that bone marrow. Right? We wanna kill off that bone marrow because then we wanna give them an infusion of healthy bone marrow cells. Okay? And what should happen? Hopefully would happen.
They start producing their own
Yeah,
healthy.
the bone marrow starts producing healthy blood cells. Okay. What can we give to help that body stimulate more cells? We can give Epogen, we can give filgrastim. Right? Okay. Now it takes about 14, maybe 21 days for that bone marrow to start functioning healthy. Is that patient at risk those first 14 to 21 days? Right? Patients in a bone marrow transplant unit. Right? They are there, and what are you protecting them from?
Oh,
Infection, right? Direct infection. Usually they're on antibiotics, antifungals. Okay? Very strict aseptic technique. Okay? Because what happens? They get an infection. Do they have anything to fight it? They could die.
And the body reject.
Absolutely.
Yeah.
Yeah, absolutely. The body can reject it. And in that case, you could try again. Hopefully try, but you want to try again.
So at that point, when you killed all the cells, basically the body doesn't have the new cell, is it just? Kind of,
You can give some of those blood stimulating agents to hopefully give them some protection. But yeah, but they can have, it's called graft versus host disease, and the body actually attacks it. It doesn't. Patient can get very sick. I mean, yeah, they could die from it if they don't take the blood trans. Yep.
Is there a reason that it happens?
The whole process again, yeah. Is there a reason?
Mhm.
It's just like anytime you have any type of like organ transplant, blood transplant, it can just reject it just based on your body that it's foreign. So that's why it's better to have your own or somebody very close versus a donor. Body doesn't tend to reject it as much.
So if you take the healthy stem cells like out of your cell, like how does that work? Like,
Yeah, they would have to, I don't know what the process is called, but they would have to go through and filter. Get the healthy cells out versus the cancer cells. Yeah, so they can filter those out, yep. That's the best way to do it, but often sometimes it won't work, so they'll have to do a donor. Anybody on the registry for bone marrow? Registry, there's one. All you gotta do is put like a mouth swab and be on a registry. Yeah, you can donate if somebody would be a match, you could donate your stem cells to somebody.
What match, what do they compare?
Oh, there's all these like HLA antigens that are on your body, just to match as close as possible.
is it on the website? If I did something like that.
It'd be the match, I think it's called. or-
Yes, I did that.
Yep. You can match. Mhm. All you have to do is like an oral buccal swab.
It's free.
Yeah, it's free. I've never been called, I'm really hoping that would be. Okay, so that is one intervention, right? So we need to make sure our patient doesn't develop an infection, doesn't bleed, right? So it could cause an injury. And our patient could be tired, right? Fatigue. So that would be possibly through treatment, chemotherapy, radiation, stem cell transplant. Okay, so think about what interventions you could assist that patient. All right, one thing, we talked about neutropenia, right? Absolute neutrophil count, ANC, right? The actual number of of mature circulating neutrophils. Okay, so if you have a client who has leukemia, going through chemotherapy, they'll often check the ANC. Okay. When we get down to moderate to severe risk, okay, do we have to do any special precautions? What would you teach that patient? If they're severe, what are we teaching that patient? Right, they don't have enough normal circulating neutrophils. Stay away from sick people. If they have to go out, what should they do?
Wear a mask.
Wear a mask, right? If we're in the hospital setting, right, these patients are gonna be in neutropenic precautions, okay? What kind of airflow room are they gonna be in?
Negative.
Yeah, what happens there?
Negative.
So when I open up the door, what should happen? The air should not go in, right?
Should
The air should
push
come
out.
Right, so I'm not bringing any infectious air in. Whereas a negative airflow room, like if a patient has tuberculosis, I open the door, what should happen? Stays in, right? Does that make sense? If I have a patient who's infectious, I don't want them, if they're infectious, I don't want them spreading everywhere else. It's gonna stay in there. When I have a patient who's neutropenic,
So we
I
want
need
to
to push
pause.
the air out, right, so that we don't bring any of that negative air, that air in, if that makes sense. Okay, so this might be another lab value that you'll see. The patient might say that the ANC is 1,500. Okay, minimal risk. The ANC is 2,500. That's good. Okay. So another test to look at. If it's low, they're gonna be in neutropenic precautions. All right, here's a question for you. Read through it, and then we'll talk about it as a group. A child with leukemia is being discharged after beginning chemotherapy. Which instructions will the nurse include in the teaching plan for the parents of this child?
B.
B, avoid fresh vegetables that are not cooked or peeled.
Yes.
Is that at risk for bacteria being on those?
Yes.
Okay. Provide a diet low in protein.
Mm. We want high protein.
Notify the doctor that the child's temperature exceeds 102.
Yes, but you should set a lower.
To be lower, right? Even like 100, right? Usually we say 100.4 is a fever. That's considered a fever, a temperature, right? 100.4. But even anything like an 100 for a child who's going, or anybody who's going through chemotherapy, who's neutropenic possibly, we need to know earlier in the year. Okay. Increase the use of humidifiers throughout the house.
No, introduces bacteria.
Yeah, think about standing water, right? Standing water, that's gonna introduce bacteria. All right, good. All right, I'm gonna skip this. We don't have to worry about this one. I'm not gonna cover this. I do want to talk about malignant lymphomas though. We talked about leukemia, which is a cancer of the blood. I want to talk about lymphomas. Okay, so lymphomas are cancer of the lymphoid cells and the tissues. Okay, so it's a solid tumor. Okay, it's an overgrowth of those lymphocytes. Okay, and what we're going to look at is Hodgkin's and non-Hodgkin's. Okay. Does anybody know what kind of signs and symptoms the client might present with if they have lymphoma? Yeah, those are large. Yeah, good. Yeah. So usually it's in the neck, right? The neck, sometimes it's in the axilla, sometimes it might be the groin. Yep, yep. So it's a large, it's usually a painless enlargement, a lymph node that's, swollen, but it's painless. Okay. Are there other signs and symptoms that kind of go along with cancer? Fevers, weight loss, like unintentional weight loss, and night sweats. Yep, those are big ones, right? That might tell you that the patient has some type of cancer. So those are some ones to educate about, right? Okay, so the patient has or can have a lymph node, right, that's swollen. We have Hodgkin's and non-Hodgkin's. So Hodgkin's is more you'll see in your teenagers, young adults, and then maybe later on in 50s or 60s. Okay, this type of cancer responds very well to treatment. Okay? And what you will also know with Hodgkin's is when they do a biopsy, they will see what's called the Reed-Sternberg cells. And that's just a cell that's found in Hodgkin's lymphoma.
How do you spell it?
Reed-Sternberg, Reed-Sternberg. Non-Hodgkin's, okay, usually you see this in older adults over 60, okay? This one spreads a little bit less orderly, meaning diagnosis, it might have already spread. It might not just be localized, it might have already metastasized. Not as easy to treat. So biopsy, right? We're gonna get a biopsy of that node, okay? Reed-Sternberg cells are gonna be found in Hodgkin. There will not be any Reed-Sternberg in non-Hodgkin, okay? And then treatment kind of depends on what type, okay? Sometimes they'll do chemotherapy, sometimes they'll do radiation, sometimes they'll do immunotherapy. Okay, so there's different treatments and it's based on, the patient.
Your location, right?
The patient, yeah. So let's look at our little demo. Okay, 75-year-old who visits the primary care physician with GI complaints, weight loss, and overall not feeling well. All right, does that tell you, oh, this patient has this disease? No, right? You never know, right? There's so many, what does GI complaints mean? Right? That could be anything, from nausea, diarrhea, constipation. Okay, but you do notice that there is an enlarged cervical lymph node. Okay. So blood work and a CT are done, followed by a biopsy. Okay, and again, what information are you going to get from that biopsy?
If there's cancer,
Yep, so the lymphoma, we're talking about what? What cells we're looking at? If it's- Yeah, Reed-Sternberg, yep. Okay. So, lymph nodes, what would you ask them about the lymph nodes?
Are they painful?
Are they painful? Okay, what else?
What did you notice?
When did you start noticing them, right? Because you can have not feeling well. Have you ever had a sore throat, strep throat? What happens to your lymph nodes?
swollen.
They get swollen.
Do you have
right?
trouble
You
swallowing?
have trouble swallowing, right? Is that normal? If you have an infection, the lymph node helps, right? Okay, so we just can't just go based on that, right? We have to find out more information. What else might you ask them?
You notice them anywhere else?
Okay, anywhere else? Yeah, good, right. What else?
Have you been tired lately?
Tired? Okay. What does not feeling well mean, right?
Mhm.
Okay. Fevers? Any weight loss? You had GI complaints, has he lost any weight?
It says weight loss.
And weight loss, yep. How much?
How much
Yeah.
over?
Is
how
it
long?
5 pounds in 2 months or is it 20 pounds? in a
Was it
month?
intentional?
Is it intentional, right? Yep. Okay, so kind of finding out more information about that. And I know that this is wrong.
There's a dash?
All right, so the biopsy still shows Reed-Sternberg cells. So we're thinking this patient has Hodgkin's, okay? So we'll do staging, right? So staging can be done based on, there's different types of staging, right? So this staging tells me what? 1, 2, 3, 4. What do you notice about that?
How affected?
Yeah, how affected? Stage 1 is what? What, right? So right in that cervical area. Stage 2, now we have 2 regions. Stage 3, now we've gone below the level of the diaphragm, and stage 4 is now we've got metastasis, right? The bones, the liver. Okay, so the doctor will look at that staging. They'll figure out with like PET scans, okay, CT scans, and then treatment will depend on localized, right? Is it localized or is it metastatic? The localized, right, we might just do some little chemotherapy, maybe some radiation. What about the gentlemen that are younger with Hodgkin's and they have some of the lymph nodes in the abdominal region, lower region?
Reproductive issues.
Yeah, so think about reproductive issues, right? So what could we offer for men of childbearing age? They want to have children, but we're gonna do some radiation to that groin area.
Saving the sperm.
Yeah, sperm banking. Okay, so donating, right, saving that sperm, sperm banking, donating, and then putting that in the chat if the male would like to have children later. All right. Here is a question for you. I'll let you read through that. And then we'll talk about it. The nurse is reviewing the complete blood count of a client admitted with an elevated temperature and acute abdominal pain. Which information will be most important for the nurse to communicate to the healthcare provider?
C.
C, neutrophils. This is what type of question? Which information will be most important? Yeah, it's a priority question, right? So if you haven't already, Michelle went through some of her test taking strategies since that video was posted on Blackboard and the announcements, right? So on these questions that you're gonna see, right, they're gonna be true, like you're looking for the true answer. We can have negative stem. What does negative stem mean? Wrong, right? We're looking for the false, the wrong answer. Or it can be priority. What are we gonna do first? Why are neutrophils most important here?
Infection.
Infection, and it's the highest,
It's, yeah.
value.
It's the most out of range. And we have a client with an elevated temperature, pain, and now we have a high neutrophil count. Yep. Okay. Other ones are just slightly out of norm, okay? Again, you will get normal ranges for your labs, okay? So you don't have to memorize those. Unless you want to, you can. I think your brains are full enough of other information. All right. Questions on white blood cells? So left shift, ANC, leukemia, lymphomas. What else we talk about? Chemotherapy, radiation, bands and blasts, segs, good. Okay, so the last unit we're gonna cover is platelets then. Okay, your thrombocytes, also known as thrombocytes, help in the clotting process. Okay. Thrombopoietin, what do you think that is? Yeah, it's a growth factor, right? It's that growth factor that's made in the liver. Okay? Liver helps with our clotting, yes? What happens to a patient who has long stage cirrhosis? Are they at risk for bleeding? Yeah, right, because that liver doesn't make enough clotting. Okay. Normal count 150 to 450,000. All right, so a couple things that I want to look at here. Thrombocytopenia purpura. So thrombocytopenia, right? That's low platelets. What does purpura mean? Have you heard of that term, purpura? Petechiae is what? What does petechiae look like? Kind of like those red, like pinpoint dots, right? What's purpura? Bigger bruises, right? It kind of is more of a picture in here, right? That's more of your petechiae. You might have more purpura. We have more larger bruises in the area. Okay. All right. So when we have thrombocytopenic purpura, we're talking about not enough platelets. Okay. So we can have a destruction or a reduction of our platelets. Okay. There's different types You've got autoimmune, thrombotic, and heparin induced. Okay, autoimmune used to be known as idiopathic. What does idiopathic mean? You ever see that term idiopathic? Unknown cause, yep, unknown cause, okay? Now they're thinking it's more of an autoimmune problem, okay? So autoimmune meaning the body destroys itself, right? So here the body is destroying the circulating platelets, okay? If we don't have enough platelets, do you think we have a problem with our clotting?
Yes.
So what are you gonna see? Bruising, purpura. What else might you see? Or notice if you don't have enough platelets circulating? Gum bleeding. Where else might you see bleeding? Stools, increased menstrual flow, yeah. Stools, nosebleeds. Sepsis, yeah. Okay. Right, so looking for those. If it is an autoimmune disorder, how do we treat an autoimmune disorder? Yeah, steroids, corticosteroids. Okay, what do corticosteroids do? Suppresses the immune system, right? Suppresses the body from attacking itself. Yeah, good. All right, thrombotic thrombocytopenia purpura. Okay, thrombotic meaning what? Thrombus? Clot, okay, a clot. Okay, low platelets, right? So we have thrombotic, but we have low platelets, okay? So blood clots are being formed in the body's small blood vessels. Okay? And so we have more clotting that's going on, and then it uses up more of the platelets. Okay, therefore, we don't have as many platelets that are circulating. Okay, so again, bruising, bleeding can happen. Okay, if we have clots that form throughout the body, what are we at risk for? Strokes, MIs, yep, good. And then what about, I have a slide on this one. We'll talk about HIT here. Heparin induced, I have another slide for that one. Okay.
What's the treatment for thrombotic?
Sometimes they'll do fresh frozen plasma, so that'll increase the amount of clotting factor. Sometimes they'll do, like a plasma exchange, where they kind of take out those, bad antibodies, I guess. Okay. Sometimes glucocorticoids can be used too. All right, I have a slide for HIT, so we'll talk about that one. So, looking at the skin, we talked about, we might see petechiae, we might see purpura. Okay. Platelet levels are going to be decreased, right? If we have this. Clotting time, do you think clotting time might be increased?
Increased.
If we don't have enough platelets, is our clotting time gonna be faster or slower? Slower, yeah. There's the arrow. It's backwards.
Yeah.
I know what I meant in here, it just didn't come out here. Right, so it's gonna take longer for the body to clot. Our clotting time is gonna be
Clotting time
increased.
too.
Yeah, did I say that or not? Did I say decrease?
I said it right.
I think we said both.
Yeah, what you were throwing down.
Okay, you picked up what I was throwing down, kind of?
Clotting time increased.
Clotting time increases.
Because the clotting time slow.
Yeah.
Yes, takes longer for the body to clot.
Okay.
Okay, so interventions. So again, clients at risk for poor clotting and risk for bleeding. Okay, so a client might need platelet transfusions. They might need fresh frozen plasma, which are your clotting factors that can be given. We talked about immunosuppressive therapies given. Okay. If we have a thrombus that can form, we might need anticoagulants, right? So we don't have any thrombus that are forming. All right, Which would be the best nursing action in the care of a client with an acute exacerbation of polycythemia vera? So best action, right? So we're looking at priority. I heard A.
A, thin that blood.
Correct, you said that one. Yep, A is correct. So maintain hydration. What about bed rest?
No, we want them
They
moving.
want them to.
I think them get that blood moving, right?
Don't want it to pool.
Monitor pulse oximetry. Okay, but is that priority?
No.
Right, if you can only do one thing. Hydration is gonna be, we're gonna be assessing that versus pulse ox. All right. The last couple things we'll talk about is some bleeding disorders. We got, hemophilia. So hemophilia is a hereditary. Again, it's usually males. Okay, there's different forms. There's hemophilia A, which is the most common, and that is a deficiency of factor VIII. And then there's hemophilia B, which is a deficiency of factor IX. Again, this is usually happens in males. And do you know when this is often first diagnosed? What's that? By 3, yep, so sometimes it's toddler age, because what happens, anybody ever have a toddler? What toddlers do?
Run into
They run,
everything.
They run, they fall down. Right, but even before that, sometimes boys, yep, circumcision, boys can be diagnosed at circumcision, right? That's that kind of that first few days of life. And we might notice that that baby is bleeding longer, right? Than normal. Okay, so I have to look to see if they have hemophilia. Okay, so they bruise easier, right? They can have blood in their urine. Epistaxis, right, nosebleeds. So they have prolonged bleeding. Okay, a lot of times where also they bleed is in their joints. Okay, look at how disformed, you can see that, how disformed the joints can come over time. It might be elbows, it might be knees, right, extra blood. When they have this, so they don't have enough factor, they bleed, and they bleed into their joints, which can cause pain, deformity. So we need to watch for bruising, we need to watch for bleeding. Okay. How do we treat it? If we have a deficiency in factor VIII,
Give them factor
give them
8.
factor VIII. If there's deficiency in factor 9, replace that. Okay. So this can be done at home. Okay. Some patients will have a central line, some patients will have a port. Sometimes parents can be taught to put in a butterfly and give that patient the factor when they're missing it. Okay, they don't have to come in every day to get factor. Depends on the patient. Maybe every couple of days, maybe every couple of weeks. Every patient's a little bit different, but they will receive that factor. Okay. If there is an injury, okay, one thing you can also do is RICE. What does RICE stand for?
Rest, ice, compression, elevation.
Okay, if there's an injury, that would be something we could do. Okay, so replacement factors, rest, ice, compression, elevation. What about activities for these children or adults? Non-contact,
yeah.
right? We're not letting them play football, rugby. Okay, we want to protect them from injury, which can cause some bleeding. Head injuries can increase bleeding, joints. Another drug that we'll talk about for this one and von Willebrand's is desmopressin. I don't think I added that on your list. Desmopressin. We'll talk about this one a lot when we get into endocrine. But desmopressin helps with vasoconstriction. Okay. It's a vasopressor. Helps with vasoconstriction. So vasoconstriction is going to help stop bleeding. All right, von Willebrand is pretty similar to that, right? We have a either underproduction or dysfunction of the von Willebrand protein. Okay, another inherited disorder. There's different types. There's mild and there's more of a moderate, type 1 and type 2, but they are missing the von Willebrand factor. Okay. So what they have to do is replace it. So usually they replace it with von Willebrand factor and also factor 8. Okay. DDAVP, that is another name for desmopressin. Okay, we just talked about. Okay. That is going to help with vasoconstriction and help to stop bleeding. And that can be given intranasally. Again, bleeding can happen just like it can for hemophilia. So watching for excessive bleeding. All right. After a dental procedure, a client with hemophilia has mild pain. When giving discharge instructions, which analgesic would be prescribed? Give you a second to think about that. So what's our key word here? There's some keywords. Who's our client?
Hemophilia.
Hemophilia. Okay. What's another keyword?
Mild.
Mild. Client has mild pain. Okay, so we need to give discharge. What would you prescribe?
C,
C, acetaminophen. Okay, why?
because it's not an NSAID.
Okay, it's not an NSAID. Why would you worry about NSAIDs?
Bleeding.
Bleeding. Okay, so morphine, why not morphine?
It's only mild.
Mild. Okay, aspirin is. Yep, aspirin is antiplatelet, and then amitriptyline is. Tricyclic antidepressant. Okay, can be used as a co-analgesic, but not in this case, right? All right. Last two things I want to talk about are DIC and HIT. Okay, so DIC, disseminated intravascular coagulation. Okay, so a very life-threatening occurrence that can happen. Okay, the client has thrombosis and hemorrhage. Okay, often happens in an acute setting. Patients admitted for like a trauma, happens a lot with sepsis. Okay, what is sepsis? When you have high septic infection, right? The infection has left wherever it was, the lungs, and now it's in the blood. Okay, okay, so severe. A lot of times with trauma, like with burns, with sepsis. Okay, so we have hyperactive clotting. Okay, this hyperactive clotting obviously forms clots throughout the body. Okay, if we have clots that happen throughout the body, we can have them in our peripheral, we can have them in our organs, right? Okay, not good, right? Okay, so it's going to deprive the extremities of oxygen, it's going to deprive the organs of oxygen, and then it's going to cause damage. Okay, and then we use up all these clotting factors, all these platelets, and then what happens? We don't have enough platelets. The client starts to bleed and hemorrhage. Okay. So early assessment is key for these clients, right? If we know we have a patient who is septic, right? A lot of times we're going to see this in ICU settings, right? Why is that client there? Right? Do I notice some petechiae? Do I notice some bleeding? Right? This might tell me that this patient is starting to have some DIC. So how do we treat it? We want to treat the underlying cause. If it's sepsis, how would we treat it? Antibiotics, right? We can give some clotting factors. Okay. Some patients have lost limbs, right? They've lost maybe fingers, toes, whole limbs because of again, this thrombus that form, don't get enough oxygen to that periphery. Okay. So find and treat the cause. Fresh frozen plasma, those will be your clotting factors. Okay. Heparin to prevent any of those thrombus from forming. Vitamin K. Right, anticoagulant there. All right, and the last one I talk about is heparin-induced thrombocytopenia. Okay, you guys are gonna be giving them quite a bit of heparin this term, if you're in clinical, okay? Almost every patient we care for is gonna be on heparin. Sub-Q heparin, why is that? Why would we give our patients subcutaneous heparin twice a day?
They're not up and
Okay, they're
around.
not up and walking, so they're at risk for
Clots.
blood clots, right? DVTs especially, okay? So with heparin-induced thrombocytopenia, what do you think is causing low platelets?
Heparin.
Heparin, right? So a patient is getting heparin. Usually we're giving them heparin to prevent clots, yes? Okay, we want to prevent a DVT, so we're giving them heparin. But now what happens is this patient is given heparin, they have a reaction to it, and now they actually develop more what we call hypercoagulability. So they're forming more, their blood becomes more thick or clots form. Okay? So instead of preventing it, it can actually cause it. So women are more at risk, exposure to unfractionated heparin, using heparin longer than a week. Okay? So if I'm giving a client heparin every day, right, to prevent, and then all of a sudden, I notice that their right lower leg is swollen and red. What do you think? Okay, what do you think I need to do?
Stop the heparin, call the provider.
Call a provider, right? Stop that heparin. What else should we be looking at? Thrombocytopenia, what do you think we should be assessing? If we haven't had it drawn already. Thrombocytopenia is what? Your platelets, right? We need to check our platelets, right? What are our platelet levels? Okay, so we're gonna have a drop in our platelet levels, but we're gonna have thrombus that can form. Okay, so we're gonna DC heparin. We might be started on a direct thrombin inhibitor, or sometimes they'll just be put on warfarin. Okay, again, warfarin will help to prevent clotting. Okay, warfarin, what do we need to check for warfarin to make sure it's effective? INR. Okay, a normal INR is 1. If I know it's therapeutic, the INR should be what? 2 to 3, right? It's therapeutic. It's gonna take longer. All right, last 2 questions.
Sorry,
Yes,
can we give protamine sulfate at all when someone has this? Like the antidote for
I haven't seen that as a treatment for it.
Okay. It just occurred to
Yeah,
me. like,
yeah, I never thought about that. Somebody Google it. Michelle, now you have to Google that and see if that's a.
All right, got it.
All right, because protamine sulfate is the antidote for heparin. Too much heparin, protamine sulfate. Too much enoxaparin, protamine sulfate. All right, the nurse is assessing a client who has been diagnosed with polycythemia vera. Which manifestation will the nurse anticipate finding?
You do not give protamine
You
sulfate.
don't give protamine sulfate.
No, it actually says it can actually trigger a similar reaction in some patients due to the development of antibodies against protamine, which is then called protamine-induced thrombocytopenia. So you could cause it different probably.
Thank you.
Uh-huh.
I'll include that next time. All right. Polycythemia vera, what do we anticipate? Receipts?
Yeah.
What's happening? What headaches?
It's not good.
Not good enough.
Not good enough
oxygen to the brain, dyspnea. It's harder to travel, claudication. Exactly. Pain, right? Especially lower extremity, right? Pain when you walk. Does that make sense? You got all those extra blood. Good. All right, an older adult client has a history of iron deficiency anemia and has not been consistent with taking oral supplements, iron supplements, because of problems with constipation. What do you expect to see for your lab values? Okay, our client has iron deficiency anemia, but they're not taking their medications like they should. which is probably most consistent with that.
D.
D, yep, a low hemoglobin, low hemoglobin level, yep. E, good.
Are you able to explain that a little more? With like, like, I'm assuming with like hemoglobin tests for iron levels, is that?
Yep, so iron deficiency anemia, so you're looking at your H and H. Yeah, and that could be low, your red blood cells could be low, yep. All right, take a 10-minute break. I'll come back at 11:15. We have a few activities to go, and then we'll be on our way. All right, so we have a 48-year-old who is here for a history of depression, pre-diabetes, and rheumatoid arthritis. She is recently divorced, works full-time as a nurse at a long-term care center, and has two teenage daughters. Okay, she's presenting today with worsening RA symptoms. This latest flare-up has lasted 3 days, and the pain is getting worse. Her current meds are methotrexate and sertraline. Okay. So what type of pain did you say that TR was experiencing? Tiffany. Okay, so rheumatoid arthritis, what kind of pain?
Chronic.
Yeah, chronic pain, but now she has a flare-up.
Acute.
Yeah, could it be both? Can
Yes.
she have chronic pain and then have acute on top of it?
Yes.
So what other information would you want to obtain from TR regarding her pain, Amanda?
How long?
Okay. Okay, yeah.
With joints are affected.
Yep, which joints are affected, specifically where? Can you point or tell me? Yep.
Have you tried
Rating.
it?
Yep, so pain rating,
Have you
good.
tried anything else?
Okay, tried anything else? Good.
What triggers your pain other than palpitation?
Okay, what other triggers? Good.
How does it affect your daily
How's
life?
it affect your daily living? Good.
Do you have any pain patterns?
Pain patterns, okay, good questions, good questions. Okay, so rheumatoid arthritis is what? What kind of autoimmune, right? Affects usually both joints, bilateral, okay? All right, Alyssa. Prescribe prednisone 10 milligrams every other day and ibuprofen 200 milligrams 3 times a day. What teaching are you providing with this medication, these medications? Why don't you just do the prednisone?
For prednisone, I put, like what it's used for.
Okay.
So, specifically for this patient, it would reduce joint inflammation, which will then in turn reduce joint, pain.
Okay.
I also put to take it with food, as that will reduce the risk of gastric ulcers, stomach irritation, and GI bleeding.
For the prednisone?
Yes.
Yeah, okay, okay.
And then common side effects, such as, swelling and edema, insomnia, weight gain,
Okay.
upset stomach.
Good. With prednisone is what class of medication is it? Corticosteroid, yeah. And so it says to take every other day, right? Which is, it's okay schedule. What about stopping it?
Not abruptly.
Should not stop, verbally stopped a corticosteroid, right? Because the patient can go into Addisonian crisis. Take as prescribed. Yep, good. Now, what about ibuprofen? Anything teaching there?
Do not exceed, your prescribed unless told otherwise.
Right.
Watch out for GI bleeding. Try to avoid other NSAIDs.
Yep.
And should avoid alcohol.
So 200 3 times a day is how much then?
600. That's fine.
Usually we say for RA like 3,200, so that's really quite small. Okay. All right. Mary, pancytopenia can occur with client taking methotrexate. So what is pancytopenia? Okay, all blood levels are low. Good. Yep. And what is methotrexate? That was one of the medications that she is prescribed that she takes every week. You know what kind of medication that is? What is it? Yeah. Yeah, it's a DMARD, right? So disease modifying anti-rheumatic. Yep, okay, so that can be a side effect, right? Is having pancytopenia. Okay, so what interventions? I say it wrong. That's what I was gonna say. I was gonna say Kira. I had to really think about it. I want to call you Kira. but Kira. No, you have to look on it. All right. What complication would you need to hear about if the patient had pancytopenia? Yeah, actually, definitely one. What else? And I told you white blood cells. What about your platelets?
Clotting,
Bleeding? Yep, bleeding, clotting, good. And then what about red blood cells?
oxygen.
Oxygen, yeah, good. All right, Austin, she wants, can I take some morphine? I think this would help the pain. I had this once when I had surgery, took my pain right away.
Opioids are more effective for like acute.
Okay,
Pain management.
okay.
and
Is she having some acute
It's
pain?
acute pain, but it's
Yeah.
acute, not chronic, so.
Yeah, yeah.
But, I said they're not as effective for like joint pain, so.
Okay.
And then has so many unwanted effects, including nausea, dizziness, fatigue. Taking opioids with the flare up. Isn't recommended, and analgesics are a better choice. So.
Good. Hopefully she'll be like, okay, that was really good, thank you, right? Or she'll be like, no, I want that morphine. Okay,
I
so
mean, we
morphine
could.
isn't always great for, you could try it, but I mean, like you said,
wanna
it's
try other
education.
Yeah.
Like you don't want them to think, oh, this is how it's gonna be at home, because you probably won't be prescribed that.
You want
Yeah.
options first.
Yeah, so what else could you do besides, did you say, besides morphine? What other, did you say options?
I was just saying the general like NSAID use.
NSAIDs,
Yeah.
okay, maybe increase in our NSAIDs,
Non-pharmacological,
non-pharmacological, right?
physical therapy.
Physical therapy, heat always helps. Were there any other co-analgesics?
Is that like hydrochloroacetaminophen?
Yeah, what else? Well, that would be an opioid. What would be the co-analgesics we talked about? Tricyclics, gabapentin, right? Okay.
Yep.
Is she on sertraline?
Yes,
What's that for?
depression.
What class is it?
S.
Class is it? Is it an SNRI? Does that also be used for pain?
Mhm.
I don't know, so I'm asking, I can't remember. Somebody tell me, is it SSRI? Okay, so do you think maybe we could try an SNRI that maybe would help with depression and maybe pain?
Yeah.
I don't know, I just work here, I'm not the doctor, right? Okay. All right, let's see, where are we? Taylor. Omeprazole, tell me about that medication. John. You know what class it is? Omeprazole, so all our prazoles are gonna end at. What class? Courtney, you wanna help her?
And I take it every day.
Michelle?
Proton pump inhibitor.
Good job,
yeah.
Emily. PPI, a proton pump inhibitor. Why would we need a proton pump inhibitor while we're taking these medications? Logan?
Affects the stomach lining, so we don't get GI ulcers. and stuff like that.
Absolutely, good job. Okay, and non-pharmacological therapies. What would benefit her?
Physical therapy.
What would be some options you could provide? Stretching, hot, cold. Prayer, meditation, yoga, acupuncture, mindfulness, guided imagery. We go on and on and on and on. Is it gonna work for each patient? No. Okay. Tailor it to each patient. Good job. All right, questions on that one? All right. This is an example of your bow tie that you will see throughout your NCLEX questions. So this client is 6. She has sickle cell disease. Okay, anything in the history that is concerning?
Sickle cell.
Okay, sickle cell,
Upper respiratory infection.
upper respiratory infection, pain, 7 out of 10.
Allergic to penicillin.
Allergic to penicillin. Okay, how about her vital signs? Pulse is
Res-
on the low side,
respiration is high.
respirations are high, pulse is high. Pressure is low. Is that low for a 6-year-old?
It is.
Yeah.
Is it normal? Or is it low?
Yes.
It's normal for 6-year-olds. Yep.
O2 is low.
But O2 is low, okay? Weight's okay.
Mhm.
Immunizations are up to date. Heart looks good. No cough. No murmurs, chest pain or cough.
no.
Yeah, no, so nothing there. Okay, abdominal is soft, no nausea, vomiting, diarrhea. So what was abnormal for our labs? Okay, our H&H was low.
Low.
Okay. Would you expect that for a client who has sickle cell?
Yes.
Everything else, our white count was okay,
Mm-hmm.
Yes.
our platelets were okay,
Yep.
and our electrolytes were normal.
Mhm.
Yes. Okay, so based on this, is this client most likely experiencing acute chest syndrome, aplastic crisis, sequestration crisis, or pain crisis?
Acute chest syndrome.
Pain, acute chest syndrome.
Pain.
Okay, so acute chest syndrome, what are some signs and symptoms of acute chest syndrome? Which can happen when you have a vaso-occlusive crisis. Chest pain, hard to breathe, low O2 sats. Remember, it's like the pneumonia-like illnesses, okay? Does she have any of that?
Her O2 and her respiratory
So
infection.
would you expect that to be low if they're in a crisis?
No.
Your O2,
Yeah.
Yes.
what's happening?
You're trying to get.
Those red blood cells are sickling, right? So they're not gonna be able to carry oxygen like they should, right? So would you expect that, right? Does she have any chest pain,
No.
No,
fever,
no,
cough?
no.
No, shortness of breath? No. So most likely this patient, I would go agree with the pain crisis. Most likely the patient is having a pain crisis. Okay. What interactions would you take? If a patient is having a pain crisis, of those 5, what are we gonna do?
Oxygen and morphine. And
And
morphine.
more. Elevated above 94. And we're gonna give pain for her pain, right? Her pain crisis. What are you gonna monitor?
O2.
Pain and oxygen. Good. Yeah, pain levels and oxygen. Okay, what else might we throw in there? That's probably another intervention that we might do when it comes to sickle cell.
Bolus.
Yeah, bolus, right? Your hydration. Yep, good. Okay, but this patient most likely is having a pain crisis, so the occlusive crisis that's causing pain. All right. Good job there. All right, I'm gonna do quick here. Okay, real quick, we're gonna do